Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation, and today I want to discuss with you an initiative that was generated between the American Board of Internal Medicine and the American Urological Association. They relate to 10 things physician and patient should question. It comes to enhance the communication between doctors and patients when they discuss ordering tests. So let's go now to the 10 points that they decided are important for patient to know and for doctor to discuss it with their patients. The first issue to be discussed is the question of a routine bone scan is unnecessary in men with low-risk prostate cancer. And that relates to statistics that show that when a patient has low risk, defined as low glycine 6 and PSA below 20, that there is more likely that the bone scan will be positive. The challenge is only that when we say low risk, there are some patients that we do not know if they're really low risk because what the biopsy shows, it's only a segment of the prostate, and when we remove the prostate, we find that there are other areas that the glycine is much higher. And at times, the PSA could be misleading too. So overall, as a rule, maybe it's correct to take into account that the likelihood of bone scan is to be positive is very small when the patient is low risk, but it is the obligation of the doctor and the patient to be careful to make sure that really they are low risk and there are exceptions to this rule, and this should be considered seriously. Let's go to the second point. The second point is looking at the issue of prescribing testosterone. The issue is that men feel that the more testosterone they have, they will be more macho, but the truth is that when the testosterone is normal, adding testosterone, it was not proven in any clinical studies that it really makes any difference. We treat testosterone as a replacement when testosterone is low or when the patient has symptoms related to low testosterone, then it makes sense to order the testosterone. The next point is ordering creatinine, which is a blood test measuring the kidney function, and doing imaging of the kidney for patients that have BPH. When the patient don't have significant symptoms, the likelihood of finding abnormality is small. So the issue is that if you have symptoms to justify the test, or if you have findings to justify the test, then it's okay to order the test. Let's move to the next issue. Don't treat elevated PSA with antibiotics. First of all, it was found that you could still have cancer even if you lower the PSA when you were on antibiotics. But the issue is that, again, as I said before, if there are no symptoms or finding of infection, it's really not recommended to have antibiotics. The next point does not relate really to prostate cancer, so I will not discuss it, but they say don't perform ultrasound on boys with cryptorchism, which means boys that the testes do not go down. Ultrasound is not recommended to perform. The next point, point number 6, don't prescribe antimicrobial to patients using indwelling on intermittent catheterization of the bladder unless there are signs and symptoms of urinary tract infection. And again, we see here sign and symptom of urinary tract infection. Because if you give antibiotics to somebody with a catheter, all you will do, you will create resistant bacteria to the antibiotics. Don't obtain computerized tomography scan of the pelvis for asymptomatic men with low-risk clinically localized prostate cancer. Here again, if the patient is low risk, the likelihood of finding a CAT scan that will show you any significant finding that will change the course of treatment is very, very low. The problem is that sometimes we have evidence that the patient is not really low risk according to the criteria of low glycine and low PSA. And the glycine and the PSA could not be the only criteria to decide when to order tests or not. We must look at other markers. We must use some other point in the history, and we have to just think about it and find whether we have justification to order those tests. The next point, point number 8, don't remove synthetic vaginal mesh in asymptomatic patients. They refer to women, to the vagina, so I'm not going to discuss this. The next point, offer PSA screening for detecting prostate cancer only after engaging in shared decision making. And this is a very important point. Some people strongly feel that PSA should be done, and some people are against it as a screening tool. But we have to use common sense here. If somebody, let's say, is 85, and after doing the PSA it is elevated, if you are not going to do a biopsy because the management would be following PSA, then we could skip the biopsy, and maybe you could skip even PSA. There is no point to be aggressive on certain age group. And the patient should know that he submits himself to a series of other tests that may lead to suffering and side effects. But in my mind, it's not the fault of the PSA itself having all the problem with the side effects. I still believe it's a better idea to do the PSA because you never know what it will show. And then you have to make a good judgment whether to do a biopsy or not, or whether the patient needs to be treated or not. But at least you have some marker, and then you could also follow on that. But that's only my personal opinion. The next point, don't diagnose microhematuria solely on the result of urine dipstick. The diagnosis of microscopic hematuria that triggers an examination imaging test for the kidneys and looking inside the bladder, what we call cystoscopy, should be based only if we find red blood cells in the urine, a significant number. Some people say more than red blood cells. But the dipstick itself is really not accurate to really start triggering all these expensive tests. So in summary, we see that there is cooperation between the internist, the Board of Internal Medicine, the American Board of Internal Medicine, and the American Urological Association. They decided together to bring this point to the knowledge of the public and of patients, so they will make a smart decision whether to order a test. And I think this goes beyond the point of trying to save cost. It comes also to save a cost to the patient, not necessarily in money, but developing side effects or exposure to radiation which is not needed. If you have any question or you would like to make any comments, please call us. The foundation number is 619-906-4700, or write to us at info@pcref.org. Stay well, stay informed, and have fun. Goodbye.